Hello, everyone, and welcome to our symposium entitled Updates in Catatonia, Innovative Approaches to Clinical Challenges. We have four speakers today, and the aim is that we're going to discuss new and emerging research in the field of catatonia and tie this into clinical practice. So the agenda for today, we have a brief case to tie things together across the four topics. And then the four topics are as follows. Dr. Lee will talk about excited catatonia as a phenomenon. Dr. Beach will discuss the lorazepam challenge test and some new ways of thinking about this. I will look at zolpidem for catatonia management and how to think about that in medically complex patients. And then Dr. Daneshvari will talk about the medical complications of catatonia. So beginning with the case. So we have Miss A, who's a 28-year-old, no prior psychiatric history, who's presenting with weeks of erratic behavior following a viral prodrome. She developed insomnia, irritability, disinhibition, and psychotic features, including hallucinations, pressured speech, emotional ability. And at home, her family noticed she was definitely acting in a bizarre way. She was hyperactive, pacing, had odd postures, and alternated between verbigeration and mutism. On admission, she was noted to be hyperkinetic, disorganized, intermittently mute, had echolalia, stereotypies, impulsivity, and had purposeless overactivity. She wasn't able to maintain oral intake, and that had been decreasing over these past weeks, and had some noted autonomic instability. So when the psychiatry team consulted on her case, they noted a Bush-Francis of 22 and diagnosed her with excited catatonia, with the underlying cause being yet as of unknown. But because of the concern given her kind of prodrome, the viral exposure, the weeks of behavior setting in, there was a concern for autoimmune encephalitis, and so neurology was co-consulted. So in thinking about this case in one of our topics, excited catatonia, how is that typically diagnosed? How does that differ from other syndromes that are common terms that are thrown around like delirious mania? And when you look at the literature, how is excited catatonia typically described or present? So we'll go through that. So with Miss A, moving on to her treatment, the team decided to order, given the catatonia diagnosis, lorazepam challenge of 2 milligrams. With its administration, she had a notable reduction from 22 to 9 in terms of the Bush-Francis. And so she was thus started on 2 milligrams every 8 hours of lorazepam with initial improvement. Thinking about the lorazepam challenge test, something that can vary based on clinician preference. How is this typically used in clinical practice? Are there ways to think about using this in a more algorithmic way? How to interpret things in equivocal cases? And how do you interpret the results themselves? This is something that Dr. Beach will discuss more. With Miss A, after several days of the scheduled lorazepam, the symptoms did begin to worsen. She returned to a Bush-Francis of about 20. Her PO intake remained pretty minimal, and some of those excited symptoms still remained that were very much interfering in care. The team decided to trial zolpidem 5 milligrams after a challenge dose. After 45 minutes of having administered it, she did notice some improvement. There was reduced echolalia. She was able to engage in a conversation with the team. Her motor symptoms improved to a degree. She did still have some catatonic symptoms, but her score essentially was cut in half on the Bush-Francis catatonia rating scale. And so with that, zolpidem was scheduled every 8 hours. And so what is the role of zolpidem in catatonia management? We think about it in the augmentation algorithm, but where are the data to support its use in that way? And how would you consider using zolpidem in a patient with catatonia? I'll discuss that a bit more. Her case progressed. She switched into a stuporous form of catatonia with some immobility and mutism. And we did notice that she developed lower extremity swelling and pain, at which time she was diagnosed with a DVT. The team started anticoagulation, and because of this persistent form of catatonia that was worsening, zolpidem was titrated up to 10 milligrams every 8 hours, and subsequently lorazepam was reduced to 1 milligram every 8 hours. So we are very worried as medical psychiatrists about the complications in patients with catatonia on the medical side, and what are those typically? How should we think about helping teams in the consulting form manage these and be mindful of their development? And then Dr. Daneshvari will talk about this a bit more as well. To wrap up her case, she did have symptomatic improvement with this regimen, but her course was quite protracted. As we're familiar with, the CSF results from her autoimmune encephalitis workup took some time to result, but they did result with an anti-NMDA receptor encephalitis. Did require pretty aggressive immunotherapy, but she was subsequently treated with that, had great symptomatic improvement, and was able to be discharged with a zolpidem taper. So hopefully this case helps you kind of conceptualize and think about the four topics that we'll discuss a bit more in depth. And from there, I will pause and hand it off to Dr. Lee.
Thank you, Dr. Gunther. And hello, everyone. I'm Eric Lee. I'm a consultation liaison psychiatrist over at Brigham and Women's. Here, I'll be talking about excited catatonia, its history, recognition, and management in the CL setting. I have no disclosure to make. In this presentation, I'll be starting off by talking about the historical background a little bit, and then I'll talk about the clinical features and differential diagnosis. I'll review some literature of clinical cases and suggested managements that we can take away from these cases, and I'll end the talk with some key points. So the modern concept of catatonia was introduced by Karl Kalbaum, a German psychiatrist in 1874. He described catatonia as a distinct disease entity characterized by alternating states of stupor, excitement, and also some motor phenomena such as posturing, flexibility, echo phenomena. He conceptualized it as a progressive psychomotor illness with stages potentially leading to dementia. Emil Kraepelin reclassified catatonia as a subtype of dementia praecox, his early conceptualization of schizophrenia, and this was hugely influential, and for decades, catatonia was viewed mainly as a form of schizophrenia. Eugen Bleuler later adopted this view when he coined the term schizophrenia in 1911 and reinforcing this association. In this context, excited catatonia was often misclassified as psychotic agitation. Because it was tied so closely to schizophrenia, catatonia was often overlooked in mood disorders, medical illnesses, or other contexts, and often misdiagnosed as delirium or mania as well. In late 20th century, psychiatrists like Max Fink began to argue that catatonia is not unique to schizophrenia, but appears across many conditions like mood disorders, medical neurological illnesses, and this shifted catatonia from being seen as a subtype to a more transdiagnostic syndrome. In more modern conceptualization, DSM-4 still included catatonic schizophrenia, but also recognized catatonia as a specifier in mood disorders and a condition due to other medical illnesses. And DSM-5 further made changes to eliminate catatonic schizophrenia as a separate subtype, and instead catatonia could be diagnosed as a specifier for schizophrenia, spectrum disorders, mood disorders due to another medical condition, and as unspecified catatonia as well. Today, it is understood as a syndrome of psychomotor dysregulation rather than a disease entity and with diverse etiologies. So the excited catatonia features were already embedded in early descriptions of catatonia, and the term excited catatonia is so frequently referenced. But yet, there is very few literature on this topic compared to stuporous type. Is it because of its rarer presentation compared to stuporous type? In this study published in 1973, they screened nearly 20,000 patients admitted to the Iowa State Psychopathic Hospital. 2,500 of them were diagnosed with schizophrenia, and 10% of these patients were further subcategorized as having catatonia. Chart was reviewed for this 250 patients, and they identified 110 to be retarded type, 67 to be excited type, and 73 to be mixed type. So the excited type was a bit less prevalent, but still a pretty good portion of these patients. In this study published in 2005, 104 patients in each 2 psychiatric inpatient units in India and Wales were included and assessed. Bush-Francis Catatonia rating scale and DSM-4 criteria were used for assessment. And excited catatonia was defined as meeting the diagnostic criteria for catatonia and the presence of one or more of the symptoms of excitement, impulsiveness, and combativeness. The frequency of catatonia was 10% on the unit in Wales and 14% in India. So they were pretty similar in frequency and also in severity, actually, in those two different settings. Out of 104 patients, 8 patients presented with excited catatonia in India, which corresponds to 7.7% versus 12.5% of retarded type, and 7 patients in Wales, which was 6.7% versus 4.8% of retarded type. So again, the prevalence was pretty similar. The prevalence of excited catatonia we see in clinical setting may be lower, potentially due to the fact that it may often be misdiagnosed. Its clinical features include excessive purposeless motor activity, impulsivity, combativeness, stereotypies, which may be confused as symptoms of mania, delirium, or acute psychosis. Some features that may be more specific to catatonia include pervigiration, echolalia, and echopraxia. In the prototype model developed by a couple authors at University of Pittsburgh, they included features of perseveration, echophenomena, pervigiration, and hyperactivity, and named it broken record. The Bush-Francis Catatonia rating scale is the most widely used diagnostic tool for catatonia in clinical practice, as recommended by the APA. The scale includes 14-item screening instrument that covers all DSM-5 text revision diagnostic criteria for catatonia and a full 23-item scale for more comprehensive assessment. The Bush-Francis scale and DSM-5 criteria allow clinicians to identify and differentiate between excited type and retarded type based on the specific features they present with. DSM-5 text revision criteria require the presence of 3 or more or of 12 classic catatonia features. And out of the features, the excited catatonia features are marked with yellow arrows here. Catatonia can be thought of as a spectrum from stuporous to excited type, and the symptoms are more on the excited end, but patients with excited catatonia can also display other symptoms as well. These are the features listed on the Bush-Francis scale that are pertinent to excited catatonia. It has features previously mentioned on DSM criteria, plus excitement, impulsivity, and combativeness. To discuss some of the features briefly here, mannerisms can be seemingly purposeful, and examples include like saluting repeatedly, exaggerated bowing, overly dramatic hand gestures when talking, etc. Stereotypy, on the other hand, has no obvious goal or communicative intent, and examples could include like rocking back and forth, hand flapping, head banging, etc. You could elicit echopraxia by casually performing some simple non-functional gestures, like scratching your head, waving, crossing your arms, and observing if the patient imitates your movements. Again, the symptoms of excited catatonia can seem to overlap with other common diagnoses, leading to misdiagnosis. And here are some ways that you can use to distinguish excited catatonia from these other conditions. Excited catatonia and mania both present with increased activity, but catatonia tends to lack goal-directedness and rather shows more motor signs like posturing, echophenomena. Delirium tends to present with fluctuating consciousness, disorientation, and inattention, while catatonia has preserved orientation, but more disorganized motor activity. You could also distinguish it from agitation and schizophrenia by noting some catatonic motor features as well. I had to present this like nice Venn diagram that I took from one of the papers by Connell et al., listing features that are overlapping between these two different diagnoses and features that are more unique to each diagnosis here as well. So I would recommend paying more attention to the psychomotor rather than mood or psychotic symptoms, and checking for features that are more specific to catatonia, like echophenomena, posturing, flexibility, and doing a lorazepam challenge as a diagnostic tool if you have high suspicion. Since I talked a little bit about the differential diagnosis, I wanted to mention about delirious mania here as well. It is also known as Bell's mania, manic delirium. Some consider it to be a subtype of excited catatonia and or malignant catatonia. others consider it to be a subtype of mania, frequently but not always featuring catatonic features. It presents with acute onset of delirium, mania, excitement, and psychosis, and some karmacharya features, including incontinence, denudativeness, and some cases remit spontaneously, but lethality tends to be high. So it is important to treat with benzos as a first line, and ECT appears to be more of a definitive treatment. And among antipsychotics, interestingly, clozapine appears most likely to be beneficial and least likely to do harm in these patients. Going back to talking about excited catatonia, pathophysiology is assumed to be the same or similar to that for stuporous catatonia, but has never been studied specifically. In these studies on neuroimaging, stuporous catatonia is associated with increased resting state perfusion and hyperconnectivity in supplementary motor area, SMA, and frontoparietal regions, but with reduced functional connectivity within the sensory motor network. Excited catatonia also shows SMA hyperperfusion, but the pattern seems different from retarded catatonia. Specifically, excited catatonia tends to have less pronounced SMA hyperperfusion and may show increased activity in prefrontal and premotor cortices. These findings support the concept that both subtypes involve dysregulation of motor circuits, but with quantitative and network level differences in SMA and related regions. We may speculate that increased SMA perfusion in retarded catatonia could be reduced by benzo administration, alleviating the motor inhibition, while excited catatonia may not be as responsive to benzo. This study, published in 1998, looked at 50 patients with catatonia at 2 psychiatric intensive care units in a hospital in New Zealand. They identified 16 patients to be retarded type, 15 patients excited type, and 8 patients with mixed type. Low serum iron levels were associated with excited catatonia and malignant catatonia. There was also a strong correlation between low serum iron levels in catatonia and poor response to benzos. It is not clear if the decreased serum iron level is due to excitement and agitation alone, apart from catatonia, but they suggest that the findings may indicate that the catatonia, excited catatonia differs from retarded type, not only in symptomatology with overlap, but also in response to treatment and possibly pathophysiology. We also did some literature review of clinical cases. We identified a total of 20 clinical cases and case reports. Patients' age ranged from 16 to 90 with a mean age of 43.4. There was equal distribution in terms of gender, and underlying pathology ranged widely from schizophrenia spectrum disorder to mood disorders to autism spectrum disorder, substance-related COVID infection, etc. Bush-Francis score was available for 10 of the cases, ranging from 12 to 36, with a mean score of 25. Some common features described are listed here with stereotypy, impulsivity, echolalia, etc. Patients responded to lorazepam in 8 out of 20 cases, to ECT in 8 out of 20 cases. A couple responded to diazepam, 1 to zolpidem. 1 patient with argyrophilic grain disease did not respond to any treatments and ended up passing away later. Patients received anywhere from 3 to 20 plus ECT treatments to show response. And lorazepam dose successfully used ranged from 1.5 milligrams to 16 milligrams per day. Some other medications trialed include antipsychotics, mood stabilizers, and some NMDA receptor antagonists like ketamine or amantadine. One of the papers specifically reported 4 cases where IV dexmedetomidine was used to control severe agitation before bridging these patients to lorazepam or ECT treatments. And one other case reported a patient who did not respond to lorazepam up to 22 milligrams a day and zolpidem, but showed improvement after 8 ECT treatments. Another patient did not respond to IV ketamine and lorazepam, but improved after more than 20 ECT treatments. And patients with autism spectrum disorder, their catatonic symptoms relapsed when ECT was trialed to be discontinued or its frequency to be reduced. So what are some ideas about management that we can take away from these cases? The treatments are largely similar to those for retarded type. Benzos and ECT can be effective, and ECT may be used in benzo refractory cases. Zolpidem may be effective in some cases. lorazepam challenge test should be the same for both types. You could consider utilizing IV dexmedetomidine to control severe agitation and bridge them to like other treatments. And you could carefully taper ECT treatments and after patient shows improvement and closely monitor for symptoms relapse, especially in patients with autism spectrum disorder. Valproic acid tends to be mentioned to be more effective for excited type, but this was not discussed in this literature. So the key takeaways that I want to conclude the talk with is that excited catatonia is historically overshadowed, but clinically critical. It is often mistaken for mania or delirium, and having high suspicion at the bedside and recognizing the symptoms and using structured tools can improve diagnosis. You could consider obtaining a serum iron level, and treatments are largely similar as for retarded type, and early recognitions could save lives and prevent iatrogenic mismanagement, like giving antipsychotics that could worsen catatonia. Thank you for your attention. And Dr. Beach, Dr. Gunther, and I are actually working on the scoping review on this topic, which will handle a lot of materials that are presented here. So please be on the lookout. And now I'll hand it off to Dr. Beach.
Hi, everyone. Thanks, Dr. Lee. My name is Scott Beach. I'm a CL psychiatrist at Massachusetts General Hospital, and I'm going to talk today about the lorazepam challenge, and I'm hoping to make this as practical and clinically relevant as possible. I don't have any disclosures with regards to this talk. Some of the things I'm going to talk about today are things like choice of agent, dose, the route, the timing of reassessment, something that we'll think about as pre-test suspicion or pre-test probability, the definition of response to the lorazepam challenge, and then thinking about some next steps after the lorazepam challenge. I want to start by pointing out that very little evidence base exists regarding the lorazepam challenge, and practices vary pretty widely across the globe. There's actually very little written about the lorazepam challenge, even in case report literature. And this was a surprise to me. I was taught to do the lorazepam challenge in a very specific way as a fellow, so about 15 years ago. And I kind of assumed that that was the way that everybody did the lorazepam challenge. And it turns out that that is not the case at all, and that practices vary quite widely. The lorazepam challenge is at least in part based on what was previously a sodium amytal challenge that had been used as a diagnostic tool for catatonia. And the very first case report of using lorazepam for catatonia, that's the case that Greg Friccione and Ned Kassem and others wrote up in 1983, actually ends with a recommendation of a trial of lorazepam given 2 milligrams intravenously. And that's really the first mention in the literature of the lorazepam challenge. If we look at some of the early studies, you can see that details of the lorazepam challenge differed quite a bit from the beginning, and they still do. We only have one randomized controlled trial of the lorazepam challenge in adults. That's the Suchandra 2021 study, which you'll hear me refer to a couple of times. That study looked at lorazepam IV 2 milligrams versus 4 milligrams, and it used some specific parameters to proceed with the challenge. There's also been a retrospective study of the lorazepam challenge in children done by Lucarelli and colleagues, and they used slightly different parameters. If we look at guidelines, those also vary quite a bit. This is from the British Association of Psychopharmacology guidelines. These are their recommendations for the lorazepam challenge. This is an algorithm from a review that was published last year in Nature Reviews, and you can see a little bit of a different algorithm, and they use a slightly different approach to the challenge. And then the APA resource document, which was recently published, has its own nuances to it. So we're still in a place where there isn't great universal agreement on how to do the lorazepam challenge. To take a step back, the goals of the lorazepam challenge are really both diagnostic and therapeutic. And one of the reasons that I really like the lorazepam challenge and think that it should be a standard part of the workup for any patient who is suspected to have catatonia or for whom catatonia is on the differential is because in addition to helping determine whether catatonia is present, the LCT can also provide useful information to guide the initial treatment of catatonia. Let's break it down a bit. The L of the LCT, of course, refers to lorazepam, and lorazepam really is the preferred agent for the challenge. Especially the IV form has a rapid peak effect, a long effective length of action. It's GABA A specific, and we think that may be important for catatonia. And interestingly, it has some anti-inflammatory properties. Many of us are in a situation now where we have a lorazepam shortage and we can't get access to IV or IM lorazepam. In that situation, diazepam is a reasonable alternative. 5 milligrams of diazepam is generally considered equivalent to 1 milligram, though we don't have specific conversion for the lorazepam challenge. And it's important to note that anecdotally, from experience in alcohol withdrawal, diazepam may stack in a way that is problematic for around-the-clock dosing, though that should not impact the challenge itself. Other benzodiazepines actually don't have great evidence for catatonia. Clonazepam has some case reports in children, but not much success in adults. Midazolam doesn't seem to have an effect. So really, if you can't access lorazepam, you should be reaching for diazepam, and Dr. Gunther is going to talk a little bit about zolpidem. Another big question that we haven't really answered is what is the optimal dose of lorazepam for the challenge test? Most current algorithms recommend 1 or 2 milligrams. I mentioned that Suchandra 2021 study demonstrating that 4 milligrams is no more effective than 2 milligrams, though Geoghegan did respond better to 4 milligrams. Between 1 and 2, we don't have a head-to-head study. Anecdotally, we've observed that 1 milligram is more likely to yield an equivocal response, and so my recommendation is to almost always give 2 milligrams. The only situations in which I think about using 1 milligram are patients with respiratory compromise, and that's really my big concern, pediatrics patients, and then very frail elderly patients. And I want to put a fine point on that last one. It drives me crazy when somebody gets 1 milligram of Ativan just because they've crossed the threshold of age and are now 65. If I have a robust 85-year-old without significant medical problems, I'm still going to give that person 2 milligrams to try and mitigate against an equivocal response. Another big question is the optimal route for lorazepam. And again, there's no clear guidance from trials. Bush and Francis noted in their original study that IV lorazepam challenges elicited a marked incremental reduction in scores, and they noted that changes were often within minutes if given IV as opposed to IM, though there was no direct comparison. Some other early studies did not really distinguish response by routes and noted responses for oral medication as well. In general, we tend to recommend IV lorazepam for the challenge. If IV is not available, I would feel comfortable using IM for the challenge, but not for maintenance treatment, because I don't want to increase the fear response from repeated injections, and I don't want to elevate the CK from repeated muscle injections. All that being said, PO is probably the most commonly used, but I would encourage people to reach for IV if you have it available. Another big unanswered question is following the lorazepam challenge, when should the patient be reassessed? This is actually all over the place. Of 3 early studies, 2 of them suggested hourly assessments, and 1, the Bush-Francis study, suggested assessment at 5 minutes, followed by repeat dosing and reassessment 5 minutes later. That Suchandra study used that Bush-Francis model. So they reassessed after 5 minutes, and that was their time. Another proposal in current guidelines is from the British Association of Psychopharmacology, and I kind of like their proposal. They recommend different times of reassessment for different routes. And that makes sense. If you think about it, different routes are going to act at different time periods. Anecdotally, a common practice seems to be reassessment somewhere at 30 to 60 minutes. But the point I want to make in terms of this is we have absolutely observed patients who take up to 2 hours to respond to a lorazepam challenge, even with the IV form. So I never call a negative or equivocal challenge until I've waited that long. Certainly, if the patient has malignant features, then you want to think about treating more quickly if your suspicion is high. But again, I don't call a negative response until I've given somebody a good 2 hours to respond. In the second half of the talk, I'm going to present an algorithm that we've been using on the service for decades. This is what I was taught as a fellow, and I think it's a nice teaching tool. It breaks things down into pretest probability and then response to the challenge. When we're thinking about the pretest probability, we want to think about whether somebody has a high suspicion for catatonia or a low suspicion for catatonia. There isn't great guidance in terms of how we think about those, but I think about a few features of the case. Things that would suggest to me a high pretest probability for catatonia include a history of catatonia, a known underlying illness that's associated with catatonia, symptoms that represent a clear change from baseline, and ideally having both motoric and behavioral symptoms present rather than just one of those buckets. It's also helpful if I have a low suspicion for other conditions that may mimic catatonia, and then I might think about extremes of the Bush-Francis scale. We know that higher Bush-Francis scores do not predict more severe catatonia, and we know that Bush-Francis scores don't predict response to lorazepam, but I think it's reasonable to think that extremes of Bush-Francis scale scores could be used to think about pretest probability for catatonia. So maybe a Bush-Francis greater than 20 is a high pretest probability, maybe a Bush-Francis less than 7 is a lower pretest probability. When we think about determining the response to a challenge, that's been done differently throughout the literature. Certainly, you have to repeat the Bush-Francis score in order to determine a response. Bush and Francis originally had a very high threshold for defining response. They said that catatonic signs had to resolve to 1 or none of their 14 screening items. More recent reviews and that Suchandra study used a cutoff of greater than 50% reduction in Bush-Francis, and so that's what's recommended in a lot of the current guidelines. I want to point out that as far as I can tell, there's no real evidence base for that cutoff in catatonia. My assumption is that that cutoff was pulled from other fields, like our depression studies typically define improvement as a greater than 50% reduction. But I couldn't find any specific place where that came from. So I want to make the argument that I think in some cases that's even too strict a criteria. I have absolutely seen patients who I would say responded or partly responded to lorazepam who had obvious changes in multiple symptom domains or even a significant reproducible change in a single symptom who wouldn't have met that 50% reduction. And so I argue for a little bit of a relaxed threshold in defining response, and importantly, keep in mind that sedation alone does not indicate a negative response. So if we come back to that algorithm, the 2x2 grid, and we start to plug it in, if you start with a high suspicion and you have a positive response to your challenge, you've confirmed the diagnosis of catatonia. At that point, you want to start thinking about what the etiology of catatonia is, but you also want to start treating with scheduled lorazepam. This is the situation that we had in the case that Dr. Gunther presented. So if I'm thinking about scheduled lorazepam, I'm typically starting at 2 milligrams IV every 6 to 8 hours. Importantly, you don't want to dose that TID or QID because then you have a big gap in treatment overnight. So dose that around the clock. And I always put an order or ask the team to put a note in the order that says do not hold for sedation, because again, you want to get it around the clock, and nurses are not used to giving a sedating medicine to a patient who is asleep or appears to be asleep. If you start with a low suspicion for catatonia and you have a negative response, that's also an easy one. You've effectively ruled out catatonia. And at that point, you can consider other potential etiologies. So we've got 2 boxes in the grid filled in. Now we get to the trickier situations. If you started with a high suspicion for catatonia, but you have a negative or equivocal response to the challenge, remember that catatonia remains possible. The challenge is not 100% sensitive. You want to think about whether that case might have some predictors of non-response to benzodiazepines. And historically, those have included schizophrenia, maybe autism as well, the presence of excited features like Dr. Lee was talking about, or even a lack of fear or anxiety. Generally, in that situation, you'd want to repeat the lorazepam challenge, typically with another 2 milligrams IV, though you could make an argument for increasing the dose to 3 or 4 milligrams. You generally, again, want to wait up to 2 hours to make sure there was no response from the first challenge and to avoid stacking benzos. But if you have somebody with malignant catatonia, then you might go more quickly. If you've done 2 challenges and there's still no response, but your suspicion remains high, then you might do what is sometimes called an extended lorazepam challenge, where you schedule lorazepam around the clock for a period of 24 to 48 hours and continue to assess response. Finally, the situation where you started with a low suspicion, but you had a positive response to the challenge should lead you to consider catatonia more strongly, but should also make you think about other entities that might respond to benzodiazepines. And those include seizures, states of GABA withdrawal, or anxiety. That's going to cause me to pursue a broad workup and maybe consider an EEG. In the meantime, you have a choice between two very reasonable approaches. You could continue to treat with standing benzodiazepines while you're pursuing that workup as a means of determining whether there is ongoing response, or equally reasonable, you could take a step back and just kind of wait and see what happens over the next several hours as the lorazepam theoretically wears off to see if those catatonic signs or symptoms resume. Plugging this all into the algorithm, you've now got a nice 2x2 grid that can help to guide you in terms of your next steps after the challenge. And again, we use this as a teaching tool for our residents and fellows to give them a little bit of guidance in terms of what to do after the lorazepam challenge. I'm going to end there and hand it off to Dr. Gunther. Here are some references to conclude. Thank you very much.
Thank you, Dr. Beach. My name is Matt Gunther, and I'm going to be talking about the role for zolpidem in catatonia management. I'm currently at Stanford, the APD for the CLP Fellowship, and spend part of my time in the ICU and other part of my time in integrated care. I have no disclosures. So some learning objectives here. I do want to look at kind of the neurobiological mechanisms of catatonia and how GABA A receptor dysfunction in particular might help us understand why zolpidem can be effective. We'll compare and contrast benzodiazepines against zolpidem in terms of the pharmacology, look at where is the evidence for zolpidem in managing catatonia, and then use that evidence to apply its use in medically complex patients. And maybe this will sort of fuel future areas of study related to catatonia pathophysiology and also help us individualize treatment when we come across these cases in the hospital. So a brief overview, and I won't spend too much time on this, but really focus on the fact that catatonia pathophysiology is complex. There are multiple things that are aberrant, including neurotransmitters, affective neurocircuitry. There's the inflammatory hypothesis, but one of the predominant theories is the hypoactivity of the GABA A receptor. And as you can see on the right-hand image there, is that it leads to a cascade in different areas of the brain where there is some dysfunction. In the frontal cortices side, there's hypoactivity leading to kind of the affective or behavioral dysregulation piece. On the motor circuit side, things are a bit more hyperactive, leading to some of the motoric inhibition that we see with catatonia. And the idea is that the density and activity of the GABA A receptors are diminished in cases of catatonia. And so this has kind of fueled the idea of why lorazepam and other GABAergics are effective in treating these. And I'll dive a bit more into zolpidem in this case. So like Dr. Beach mentioned, we talked about benzodiazepines being effective, but there are up to 30% of cases where they are ineffective in terms of managing catatonia. And then we look into the augmentation algorithm or moving into ECT. And as I experienced as a trainee and moving into attendinghood, part of the augmentation includes a mention of zolpidem, but it was really unclear where that came from and what the role is of zolpidem, when to use it, and why it actually works when a benzodiazepine, another positive allosteric modulator of GABA, was ineffective. So it was first approved in 1992, again, primarily used for insomnia. So we definitely get some raised eyebrows when we're scheduling it around the clock in catatonia. 3 years later, it was used to address catatonia. And from there, a lot of the cases, like Dr. Beach mentioned, were from France and areas of Europe. So in thinking about crafting what was a systematic review published earlier this year, is there a role for zolpidem in these cases where benzos are ineffective? And why? Why, especially when benzos are more ubiquitous in terms of their effect on the alpha subunits of GABA. So just a quick reminder, the GABA A complex has multiple subunits, and zolpidem and the Z drugs were marketed to be selective for the alpha 1 subunit, really to help with sedation primarily and not have that anxiolytic effect that benzodiazepines have. Potentially that would lead to less dependence, although we know that's right? We do come across many people that are dependent on Z drugs at this point, but the idea is it's much more selective than the benzodiazepine group, which hit alpha 1, 2, 3, and 5. And as you can see, there are multiple kind of clinical effects associated with that activity. So is it by having a more selective agent in people that are critically ill, the delirious, the elderly, is there something that could be useful by having a more selective agent? And we'll look into that a bit more here. So in our systematic review, we conducted this, we can cast a wide net gathering cases of catatonia in adults only. And in doing so, with all the whittling down that comes with a systematic review, we ended up with 35 cases across 29 studies. And things fell into sort of 5 categories. One being the second line augmentation, number 5 there that I alluded to. Benzodiazepines don't work. Let's think about augmenting with zolpidem. But other categories of clinical effect were also shown in the literature. Zolpidem as a challenge agent, as opposed to the LCT as zolpidem challenge test. Zolpidem as monotherapy, either to begin with or once a prior treatment has failed. And interestingly, there were some cases where zolpidem was started concurrently with the benzodiazepine. So when we looked at the literature, things fell into these 5 discrete groups. So what were some of the highlights? And I'll dive into this a little bit more. The first thing I want to point out is the response rate. 80% of cases demonstrated a positive response, which is pretty great, especially when you consider a subset of those were included in that 27 to 30% where the lorazepam was ineffective. Average age was somewhere around 51. There was some disparity in terms of objective rating scales that were used. I'll talk a bit more about the failed cases on the next slide. But interestingly, zolpidem was frequently trialed after lorazepam-induced side effects. So I think one of the things that we've talked about, including at prior ACLPs, is someone with concurrent delirium and catatonia. What do clinicians typically do? One of the answers I heard and have used is a lower dose of lorazepam, but even that can lead to delirium, sedation, kind of an equivocal test like Dr. Beach was talking about. So zolpidem was pulled in these cases for those scenarios. Dosing was wide, and as you can see, 5 to 45 milligrams a day, that is a wide range. Keep in mind that the challenge side was somewhere between 5 and 10, and then dosing in a schedule fashion was somewhere up to 45, and we'll look at that a bit more. But typically, you see a response between 30 and 60 minutes across these cases once you administer it, even though it is oral. So diving into the results a little bit more, I mentioned the 5 categories. I'll start with the augmentation side, which was 100% effective. Granted, that was an N of 4. So this is when lorazepam typically in these cases was scheduled. An ineffective response, zolpidem was added, and it worked. As a challenge agent, it was also very effective. First-line monotherapy was great as well. Again, that's a smaller N, but the challenge was interesting in that there was a much bigger N there. For second-line monotherapy, a little less exciting, but that idea is that someone's already tried and failed a traditional approach to managing catatonia. And then when it was combined in these 7 cases with lorazepam or another benzodiazepine together, that had the lowest response rate. I'll talk a bit more about these concepts. But one thing that was interesting in these cases was there was a good amount of non-psychiatric catatonia represented, in particular neurologic and medical etiologies. And as SEAL psychiatrists, we know that catatonia can present in these syndromes, and these disorders, especially leading to a frail CNS substrate, can also make treatment of catatonia a bit more complex, right? Because they're sensitive to the agents we're using, in particular benzos and other things, when we're trying to address the catatonia. And of the failed cases, the ones that were quote unquote treatment failures or inadequate response to zolpidem, they actually weren't the neurologic ones. They were the psychiatric ones. So like Dr. Beach mentioned, in terms of some populations having a less great response to lorazepam or GABAergic therapies, schizophrenia, autism, those were the cases as well that did not respond to zolpidem. But of note, of the 7 cases where there wasn't a treatment response, there were some limitations to that group. There was a maximum dose of 10 milligrams of zolpidem, which if you look at things that is on the lower side, so was that not adequate enough? We're used to going higher on the GABAergics in these cases. And benzodiazepines in 6 out of 7 of these cases also failed as well. I alluded to the fact that maybe some populations are more resistant to this modality of treatment, and that did prove to be true. So when you looked at what did the clinicians do after that point, the typical augmentations came into effect in terms of amantadine or ECT. One case was clozapine as well. So interesting to note, so that there were treatment non-responders, but who were they and what was the dosing is important to be mindful of. So I go back to the selectivity because I think this is a very interesting point. Is there something about zolpidem's success rate, especially in cases where traditional, more broadly GABAergic agents have failed? Is there something about a selective agent that is useful here? And the GABA A alpha subunit, alpha 1 subunit in particular, has actually been shown to have abnormalities across populations, including patients with schizophrenia, depression, anxiety, patients with trauma and stress. There's some dysregulation as well. It's thought to contribute to cognitive and affective symptom burden. And downstream, perhaps alpha 1 is related to neuroplasticity. So the fact that that particular receptor can be dysfunctional has been looked at. And I think the idea is there a way to connect that to cases either that respond very well to zolpidem or don't respond well to lorazepam, which is more broadly targeting other subunits? In schizophrenia in particular, right, so far I've alluded to the fact that it is benzodiazepine resistant at times when catatonias occurring, and there are some abnormalities in the GABA receptors across the board in patients with schizophrenia, including the alpha 1 subunit here. So again, that kind of spreads or speaks to the fact that maybe this population has some resistance built in, and that we might need to individualize treatment and think about either more selective therapies or alternative mechanisms when other sort of traditional treatments fail. One thing to be mindful of as CL psychiatrists, we're always very concerned about our treatments and their impact long term, especially with delirium being ever prevalent in the hospital. And how can we choose agents that are CNS protective or are not deleterious to the CNS substrate that's already vulnerable? And so, is there something about zolpidem that can be helpful here? So one of the things to be mindful of is the idea of cognitive impairment after catatonia. And it's not very well studied, although there was a 2022 systematic review that came out that looked at there is longitudinal cognitive impairment after catatonia, in particular in the cases that have delayed treatment or more severe in the malignant catatonia side. And that's seen both on neuroimaging and neuropsychological testing. Pair that with the fact that we know the cognitive risks that exist with benzos, including the dose-dependent curve there that you see on the right with increasing probability of delirium. And we have something to think about there because if we're using, 10, 15, 20 milligrams of lorazepam a day in patients that are medically frail, sensitive to delirium, and or have comorbid delirium, what is going on there in terms of the long-term cognitive impact is something that's not well elucidated. But we know that benzos are anticholinergic. We know that there are some cognitive impairments that come along with those. And we know that perhaps the Z drugs are a little better in this regard. There was a study that looked at zolpidem versus benzodiazepines in an older population, and there was less persistent impairment with the Z drug population. So if we begin to look at that in terms of catatonia treatment, could we preserve some cognitive function in patients that are already at risk? It's a good question. This was an interesting study that looked at patients with schizophrenia with and without catatonia versus patients without in terms of cognitive impairment. And the take home here is that every patient with schizophrenia had some element of cognitive impairment, but when one developed catatonia, there was an impact compared to the non-catatonic patients with schizophrenia group on verbal fluency and processing speed that persisted. So instead, another way, catatonia did lead to some persistent cognitive impairment on top of a population already vulnerable and dealing with cognitive effects, right? Because we know the cognitive burden of schizophrenia. And so catatonia itself did lead to some cognitive impairment. But was that the fact that one has a more severe schizophrenia leading to catatonia and having that be difficult to treat? Was that the treatment itself? It's a little unclear, right? I just alluded to the fact that benzodiazepines have a cognitive burden. This is something that's not well described, but maybe could use more clarity here. So how does one use zolpidem? When should you consider it? Again, this is all based on case literature and some anecdotal experience. If one is to use it in a challenge fashion, it's somewhere between 5 and 10, again, seeing a response within 30 minutes to a couple of hours. And like lorazepam, scheduling should be done at regular intervals around the clock. What's interesting is because it does have a 3 to 4 hour half-life, you can still see a clinical effect at doses where you might not expect kind of that steady state to develop, which is interesting. And again, speaks to the little that we know about kind of its use. But I would think about using it in populations that do have that frail CNS substrate. Yes, you're concerned about sedation, but so are you with lorazepam. But is there something, again, about having a more selective agent that did well in a population with neurologic disease that has a shorter half-life that might be better for these folks where lorazepam either produces an equivocal response or is contraindicated in some way? When it comes to dosing, somewhere between 30 and 45 milligrams is where the doses had an effect. And some teams can bulk up the idea of scheduling a sleeper throughout the day. But similar to lorazepam, you're not often, well, you can, but you're not necessarily seeing a frank amount of insomnia or sedation when you're using this in a patient with catatonia because of their resistance to that side effect. The idea is, should you have both a benzo and a zolpidem on at the same time? That's still to be discussed, but in reality, no. In the cases that I've had at Stanford, we've cross-tapered sort of gently. So some things to think about. Again, the idea of the treatment then looking at pathophysiology to a more individual degree. Is there something about the alpha-1 subunit in particular populations that might deserve further attention? We know that catatonia can come from multiple etiologies. Those etiologies might require different treatments. It might not be a one size fits all, and this might be kind of the precursor to looking at that a bit further. There are limitations to this data set, definitely. I mentioned the 35 cases are cases, right? There's no head-to-head trial related to this. And the follow-up, the use of objective rating scales was pretty scattered. They didn't look at long-term kind of relapse prevention. Some treatments were as short as one time to a couple weeks to years, right? But again, this is across 35 cases. So it is kind of a limited amount there. So things to think about in the future, obviously having more cases reported to this, having some sort of cross comparison, although again, thinking about the etiologic differentiation where, a patient with neurocognitive disorder might respond a lot differently than a patient with schizophrenia. And thinking about cognitive outcomes post-treatment, I think there's a lot of room to look at, are our treatments somehow being deleterious in some way? And can we pick agents that are a little safer for folks, but being mindful of that? So with there, I will pause and hand it off to Dr. Daneshvari.
Okay, thank you, Dr. Gunther. So my name is Nicholas Daneshvari. I'm a fourth-year psychiatry resident at Massachusetts General and McLean Hospitals and aspiring CL psychiatrist myself. And so for this portion of the talk, we're going to be speaking about the medical complications of catatonia and neuroleptic malignant syndrome. I do not have any disclosures to report today. The objectives of this talk are threefold. By the end, I hope that CL psychiatrists will be able to first appreciate that catatonia and NMS are associated with specific complications, a broad range of them. Second, to recite a clinical framework for anticipating and serving for medical complications among patients with catatonia. And third, to implement clinical recommendations to help prevent these medical complications. So by way of background, I'm just going to explicitly define up front a couple terms. Malignant catatonia seems to have a pretty heterogeneous way it's defined, but often there are some specific features that are considered to be pertinent to malignant catatonia. For the purpose of our work today, we will be calling it two of the following features in a patient who has catatonia, things like autonomic instability, fever, tachypnea, diaphoresis, severe muscular rigidity, and a CK elevation. We use a cutoff of 1,000. Neuroleptic malignant syndrome is thought by some, many folks in the field, to be an overlap syndrome with malignant catatonia, or can be thought of as a severe stuporous form of catatonia with malignant features that happens to have a neuroleptic as an identifiable precipitant. But given the large overlap in these two syndromes, we'll be kind of grouping them together largely for the purpose of this talk. Catatonia, we know it's associated with medical complications. I think many folks would be able to name a handful of these, such as diminished oral intake, autonomic instability, rhabdomyolysis. We often check for CK levels for patients who have catatonia when we're getting worried. And then there are some more feared things like venous thromboses and pulmonary embolisms. And we know that catatonia can be lethal in its most extreme forms. But is there some kind of conceptual framework by which we can think about these a little bit more systematically? And what is the total breadth of medical complications that we should really be having on our radars when we're with a patient? So the state of the literature on this topic is quite heterogeneous and primarily case reports and series, of which there are hundreds. There are a handful of studies and reviews, but nothing comprehensive specifically. This realization led our team at MGH to begin the first systematic review on medical complications of catatonia and NMS, which is currently in process and should be coming out in the next few months or year or so. So our study so far has identified 283 articles that includes 364 cases and 12 studies that were included. This includes patients of all ages, including pediatric populations. We only did English language articles and searched 2 databases, PubMed and Web of Science, since their inceptions. So this is where a lot of the information that we'll be talking about today comes from. So getting into it. Which patients actually have medical complications? So we'll start with the patient characteristics and demographics themselves. So what we see is roughly an even sex distribution. You can see on the table on the right, about 50% each male and female, a very small percent is undisclosed, with a mean age of about 45, 46 years old. The standard deviation of 18. We have a range of patients as one as young as 6 months old and one as old as 96 years. But overall, it seems to be kind of an expected distribution without a huge skew in one direction or another. Again, a little bit more details in the table on the right. We see that our past psychiatric history skews towards schizophrenia spectrum disorders. This is likely related to the inclusion of NMS. So almost 50% of the patients have a schizophrenia spectrum disorder as a primary premorbid psychiatric diagnosis, though there are a number of other diagnoses involved here, of course, bipolar disorders, depressive, and also neurodevelopmental dementias, and no psychiatric history, as some of these patients may have had a medical etiology to their catatonia. So moving towards thinking about which patients have medical complications, and thinking about the characteristics of the catatonia that might be associated, we see a few things here. So first, with the etiology of catatonia, our sample was primarily dopamine blockade, again, probably related to the inclusion of NMS, though I will mention that the dopamine blockade category, despite representing almost 2/3 of these patients, did include other forms of blockade, such as antiemetics like metoclopramide. About a quarter of these patients had a psychiatric diagnosis as their etiology of catatonia. Almost 10% were neuromedical, things like NMDA, encephalitis, COVID, Parkinson's, etc. Looking at the presentation of catatonia, almost 3 in 4 about were stupor as subtype. A very small percent were excited catatonia, and a little bit more mixed catatonia, 7%. Of course, there was a chunk that was unknown or unable to be distinguished from the literature. And then we see that 3/4 of these patients had malignant features or NMS, with just a quarter of them having non-malignant catatonia, which on the one hand is unsurprising that the majority were malignant or NMS, but on the other hand also points to the fact that almost a quarter of these patients who had significant medical complications did not meet criteria for malignant catatonia or NMS. So to kind of summarize which patients do have medical complications, there are no clear demographic vulnerabilities, but what we see most commonly is malignant features, a stupor as subtype, and dopamine blockade, at least per the case report literature. So now let's think about what specific medical complications occur. There's a very broad range of them, and we'll talk in a little bit about a kind of unifying framework that can be a little bit helpful. I'd encourage you to take a little bit more of a look at this table if at your time. But we've broken it down here by organ system and what % of our case report sample had each of these complications. Just to highlight a few of the most common ones that occurred in about 10% or more of patients here in order of frequency. Almost 50% of these patients had rhabdomyolysis, which again, we defined as a CK cutoff of 1,000, or the self-report of the articles themselves. Almost a quarter, or just over a quarter of these patients had renal dysfunction, which could range from acute kidney injury to nephropathies to renal failure requiring dialysis. We see the category of respiratory impairments, whether it's respiratory dysfunction, like respiratory failure, respiratory tract infections, or aspirations were all among the more common complications. Pulmonary emboli and infarcts as well, though that's lumped under the hematologic category. And then other things like malnutrition, neuromuscular issues, which could include contractures or dysphagia, dysarthria, things like that. And cardiac dysfunction was about 10% of our patients. This could include things like heart failure, Takotsubo cardiomyopathy, and others. So while I want to highlight that these were some of the more common things, there's a whole handful of medical complications that can be very significant and severe, that occurred less frequently but could still be on one's radar. Things like acute compartment syndrome, myocardial infarctions, DIC, and many more. I'll just highlight as well that in this sample, almost a quarter of the patients passed away. This had a broad range of etiologies, but it was pretty common for it to be multifactorial, and severe shock is like one of the unifying features in the patient's deaths. So let's talk a little bit about a framework for medical complications. So we can think of 3 pathophysiologic states that occur in catatonia as kind of the starting points for anticipating what might occur. So the first one that I think about is a sympathetic surge. So patients will have autonomic instability, rigidity from that catecholamine surge, arrhythmias can occur, and then things like constipation and urinary retention actually occur due to sympathetic surges as well. So that's the first one. Next, we think about immobility. Particularly in the stuporous subtype, patients may have significant immobility lasting days at a time, and this could lead to things like muscle breakdown, increased risk of clotting or thrombosis, aspiration, depending on how the patient is positioned and if there's immobility of the laryngeal muscles. Things like pressure ulcers and contractures we could imagine occur from immobility as well. And the third category is nutritional deficits. Of course, diminished oral intake is an item on the Bush-Francis in named withdrawal. And many folks do have things like dehydration, electrolyte abnormalities, and malnutrition can occur as well. So if we think about these 3 pathophysiologic states of sympathetic surge, immobility, and nutritional deficits, we can think about starting to derive how medical complications might occur, either from just one of these 3 states or the combination of more than one of them. So we'll go through a couple examples here. So something like rhabdomyolysis, how does it actually occur from catatonia? So we have a sympathetic surge that leads to severe muscular rigidity. We have immobility that leads to muscular breakdown. And we have dehydration, a nutritional deficit. And these things can combine to make rhabdomyolysis pronounced, potentially leading to a kidney injury and renal failure. Another example is aspiration and acute respiratory failure. How might these occur? So starting with a sympathetic surge, we could have tachypnea, dysphagia. The immobility can increase our risk of aspiration, and the nutritional deficit can cause dehydration, which can impair the oral hygiene and increase risk of dry mouth, which also increases risk of aspiration. So this can all kind of come together to precipitate a state where something like acute respiratory failure happens as a result of catatonia. And third, we'll do one less maybe obvious example of a colonic pseudo-obstruction or Ogilvie syndrome. So a sympathetic surge could start by causing some constipation. The immobility could worsen the constipation, and then poor oral intake, a nutritional deficit, could decrease gut motility. And ultimately, this could result in a very severe complication like a pseudo-obstruction. So again, coming back to this framework, how are these three pathophysiologic states something that we can keep in mind? We have a sympathetic surge, immobility, and nutritional deficits. Well, one way I've come to think about it or help remind myself is with a mnemonic that I came up with called SYN, standing for sympathetic surge, immobility, and nutritional deficits. So if we think about this SYN, we can kind of start to derive the medical complications to anticipate. And it would be, one way to keep this in mind is that it would be a sin to forget about the medical complications of catatonia. So we can move now to some recommendations for management. These are nearly all derived from the studies that we have in our systematic review rather than my own editorializing. But so a few different things that we want to highlight. So there are 9 studies that gave specific recommendations for management. And so you can see per the references here how many roughly recommended each item. So early detection and diagnosis, of course, was one of the frequently recommended things. One study highlighted considering an EEG, given that they found frequent comorbidity with seizures, and starting an AED or an anti-epileptic drug if needed. Early treatment of catatonia was also highlighted. Benzodiazepines were explicitly mentioned in 2 studies, and one mentioned not delaying the benzodiazepine while awaiting other diagnostics. ECT was mentioned as well, with a specific recommendation to begin within 5 days or on the same day in the case of malignant features. Some studies also recommended things like dantrolene, bromocriptine, and anti-Parkinson drugs as well. And then antipsychotic-wise, atypicals were stated to be preferred to typical antipsychotics to reduce risk of worsening complications by one study. So this kind of highlights some recommendations for diagnosis and treatment. Here we have some recommendations about management and more like supportive and preventative measures that we can take. So some supportive measures that were highlighted: intravenous fluids. Aggressive IV fluids was very frequently cited as something that some studies named to be the most important factor in preventing medical complications. Adequate nutritional support, including nasogastric tube if needed, was recommended. And then external cooling. One study even highlighted considering an ICU transfer for this purpose. Then there's a category of aspiration precautions. One study focused explicitly on this, and their recommendations were to monitor during meals for aspiration risk, provide regular oral care to minimize risk there, and things like sputum clearance with chest physiotherapy or nebulization. Next, there was a category of recommendations around mobilization, targeting that immobility piece, of course. So reducing bed rest, minimizing restraints, and physical rehabilitation. Finally, there's DVT prevention, which one study focused explicitly on. They recommended compression stockings, and they also recommended to consider heparin, weighing that against the bleeding risk. One thing I will mention myself that I learned on my internal medicine days was considering to use this tool called the Padua score. While it hasn't been explicitly validated in catatonia, it's widely used by internal medicine folks to determine weighing the risk of bleeding when considering DVT prophylaxis or not. And the way it works is you need a score of 4 to qualify to start something like heparin. And immobility alone, interestingly, gives 3 points. So if you have a patient with pronounced immobility and any other risk factor, things like recent surgery, active cancer, obesity, elderly age, etc., those things would all give you a score of 4 that would therefore meet that threshold. So that's one tool that you could consider to use as well. Here are the references for those studies I mentioned. And with that, I will hand it back to Dr. Gunther. Thank you.
Thank you so much, and thank you everyone for your attention. Hopefully this was useful to you. Thank you to our co-presenters, and keep an eye out for some emerging literature that's coming on these topics that we discussed today. Thank you and take care.